I think we are live, Anthony. I'm just waiting the confirmation. I see it there, but I don't see it on the other side. 1 second. Yep. All right. Good afternoon. This is United Medical. Today is August 20th. And our United Medical ACO event is starting. And as usual, I'm just going to send the event to our providers very quickly. Today, we are going to go through the overall discussion that we had in the last couple weeks, and just give me a couple seconds. And all right, so. And I know our people are already sharing the event. And okay, I sent it to everyone from my list, and they should be good. All right, so today we are going to discuss, we're going to go over some of the stuff that we already discussed. There are some new items that we have. I asked Anthony Onugu, one of our directors, to join me. Anthony is one of our, as I mentioned, one of our directors. He is very much involved with what we do in the Accountable Care Organization, as well as he is one of the architects of the provider communication and one of the main elements of the team from my side. And sometimes we have our own disagreements internally just so that we can have a good discussion. And I asked him to join me to kind of go over some of the issues together. So we are going to discuss the numbers, but I think this mandate issue is becoming more problematic as states and employers are discussing, or not discussing, rather they are actually making these policies as they go live with these policies. So many people are, they are either upset or they are not sure what they are going to do. Employers are unsure what they need to do. There are some confusions. So I'm going to ask Anthony to introduce himself, and we'll start our session.
Hello, everyone. Thanks for having me, Kemal. I'm Anthony Onugu, the Director of Contracting. Been with United Medical for about 5 years, focused largely on the management of contracts, specifically the value-based contracts and the overall transition from fee-for-service reimbursement systems to more value-based and value-added care, and helping with transitioning our providers to a new approach, to an enhanced approach to the care of our patients, and looking at them not simply as individuals, but from a more holistic and population-based approach. So I'm happy to be here.
Thank you, Anthony. And I know you are actually always there because while I'm doing other live sessions, you are sending me messages, and sometimes you are sending me corrections, and sometimes you are sending me your disagreements. So I'm going to bring one of the slides from last week when we had the issue of hospitals' positions on the mandate. This is from Delaware hospitals. I put them in 2 different categories. One, they actually, before the state mandated, they started with their own internal mandates. So Christiana Care, Nurse, and St. Francis. And on the other side, Bay Health, Nanticoke, and BB did not mandate it. However, while this was happening, we have our state regulation hit the news, and this is from your PowerPoint.
Yes.
And this actually already covers acute and outpatient providers.
Yes.
And pretty much it makes the first slide kind of moot in a way that it's not relevant anymore because this overrides that first one.
Yes, because all of these facilities are regulated by the Division of Healthcare Quality, and their mandate covers all of those entities. So irrespective of perhaps the lack of a public announcement before this mandate by Bay Health and by Nantico, they are directly covered by this requirement, and are expected to implement this by the start date of September 30th.
You see, I think the communication is one of the biggest problems, and how we are communicating with public. So if the state was going to override all the decisions that these healthcare facilities were going to make, the first, when they came out with their own way of their own policies, the issue is they give this message of some are okay to mandate and some are not okay to mandate. You see where I'm going?
Yes, yes.
So this misconception, misleading of mandate is not necessarily supported or not necessary by certain hospital groups versus the other group. And then a week later, the state comes out and then says, well, everyone is going to be following this. So the confusion is already built in. So now we are trying to get out of that. So it could have been easily eliminated if state just comes out and then just makes this from the beginning, rather than just asking hospitals to make their own mandates, if this was going to happen anyway.
Yes, but part of it is, as you know, the intersection of politics in this, and it appeared that a number of the states and, of course, the federal government, as we've seen, seem to default to leaving this perhaps difficult decision to private employers initially, and then subsequently, especially as the Delta variant grew in the rapidity of its spread, now decided to invoke the legal authority that they have in certain cases to now impose a mandate. For instance, we see that with the announcement by the Biden administration and subsequently by CMS requiring all nursing home and long-term care facilities that do receive Medicare payments, requiring them to have their staff vaccinated as a condition for continued reimbursement through CMS.
So now, although one difference that I have maybe is the state employees and the state decision and the private employers that you mentioned. In this case, hospitals, although they are private, they are not necessarily fully private when it comes to the decisions like this, because they are part of the state committees. You and I, we are kind of like, we perhaps, we make this one of our issues in terms of our communication with the state from the policy-making, decision-making. So the hospitals are very much in the decision-making process with the state, so they could easily actually make this more like a proper decision, so that it would be one whole decision rather than a private employer of the hospitals and the state employees or state decision. So the point that Anthony, I'm trying to make on this one is it's the how we are delivering that message and timing of that message. So the overall communication, and there are already people who are confused, and then they already make different conclusion from everything that we say and when we say it. So it kind of gives them more arguments when there are differences, especially at the hospital levels.
Yes, in addition to the fact that it creates a discordant situation where some hospitals have the mandate and some others don't have it. The state always had the legal authority to set mandates. They always had that. It's the federal government that doesn't have that. The authority has always lied with the state. It goes back to the 1905 Supreme Court judgment in Jacobson versus state of, I believe, Massachusetts, which has set the legal standard for public health authority in vaccine matters with the states and the local counties. So that's always been well established, and the state had the authority to set this mandate and therefore have a uniform standard across the state, rather than the point you made earlier of the patchwork approach where you had Christiana, you had Nemours with vaccine mandates, and then so the other hospitals effectively waiting for the state to require them before now setting these up. You will wonder to yourself, for instance, the Christiana employees have been implementing this over the last several weeks, whereas some of the other hospitals now have to wait until September 30th. They're all hospital employees. They're all patient facing in terms of most of the employees anyway. So why that difference in standard?
So the other thing, Anthony, from your what you shared with our providers, so around the country, actually, the situation is kind of similar. So I'm going to share that slide. So it's 30% of the U.S. hospitals right now.
Yes. As at early this month, I believe, as at August 13, the estimate was for 30%. And that number has been increasing. Becker's Hospital reviews tracking these numbers. And it's expected that once the vaccine is fully authorized, rather than the emergency use authorization, that a lot of the for-profit hospitals will adopt this same approach. But it's not just the nonprofits; it's also the for-profits that are increasingly moving in this direction.
So now here's another question, another maybe issue that I see that's coming to our way. So what happens? So just if you follow my logic in this, now the reason I'm not coming up with these on my own. I'm just making this from, as you know, a lot of people, they talk to me from different backgrounds, from the professional level. This can be doctors, nurses, business employees, executives, like any group of people. So we have our doctors took the vaccine first. So as you remember, our doctors, they were on the first we saw them as the privileged people to take the vaccine, and some saw them as like the guinea pig of the vaccine study, right?
Yes.
Based on the perspective that you are looking at, or the perception that you have. So, but they took both doses first in the country. So now they believe in what they do, and they expect certain things from their patients. So at some point now, vaccine is available for everyone. And what I'm getting is some of these providers. What happens if they don't want to actually see patients who are refusing to be vaccinated for in-person visits? What happens in that case? So would it go to that level if we are not able to control the number of cases that we have today? And because doctors are going to say, look, I mean, we know vaccine works. And if you are not getting the vaccine, then you are risking not only your life, but you are risking other people's life. And I'm not making this as like my opinion. We are messengers here. So, well, it doesn't matter how I say this. Some people are going to make their own decision and we don't care anymore. So we have to do the right thing and we have to say the right thing. So, but I think I can see that's happening, that's coming to our way. Do you see that, or what's your opinion on that?
Absolutely. The average doctor is, as we know, a physician, but is also a business owner, right? And in the same way that a cruise ship company would insist on its clients be vaccinated before accepting them on a cruise, is the same way that a physician can impose a vaccine requirement on the patients who come into his or her business, and will then in turn require such a patient to be seen, for instance, through telemedicine rather than in-person visit. There is an example of this already going on in a couple of the southern states. I believe in Louisiana and Alabama. There's some reports coming up already of physicians requiring patients to show evidence of vaccination, and failing to do that, ask them to make a telemedicine appointment instead of the in-person. And it's likely that this will grow, especially if as we get into the fall, the numbers do not come down and the rate of transmission continues to increase. So overall, you will think that this is perhaps a better approach to this than the blunt instrument of another lockdown, for instance.
So again, like we use telemedicine as a prevention for patients who were actually before even the vaccine was available. So like I'm going to use a personal example. So if both my parents, before the vaccine available, I wouldn't want them to leave their home for some annual check. Like if they don't have to be physically in the physician's office, I wouldn't want them to leave their home for a doctor's visit.
Yes, and
today, even with the vaccination, my opinion didn't change.
You recall that we did share with our providers data of the flu in 2020. Effectively, we didn't have a flu season in 2020. And it directly ties into the increased telemedicine use. It ties into, of course, the aspects of the lockdown and the use of face masks, but it also ties into into increased telemedicine use and the fact that patients were not being made to come into the office, and if they did, they were essentially triaged well ahead of those visits, which meant that it provided that additional service without necessarily compromising the care of the patients or the access the patients had to the doctors, right? So it's the reason why the data out there shows that an increasing number of patients are opting to retain the use of telemedicine, except in cases where clearly there's a need for an in-person visit. And it's the basis of the hybrid model that we now are operating in the healthcare space.
And the reason I was kind of pointing that out is, so the telemedicine is not the way to avoid the care that we are providing for whether it's vaccinated or not vaccinated. So Anthony, so that sensor actually is, you just need to move. Okay, so that's 15 minutes. So Tanner always had that problem. Like we are not trying to use the telemedicine to separate vaccinated or not vaccinated, but now it may be another way of like I can tell you that there are some providers who are not comfortable seeing patients who are refusing to be vaccinated, and I'm worried that that may become a bigger problem, and we have to kind of see, because this is, just think about it, like as a provider, as a physician, as a primary care, you can be a nurse practitioner or PA, you are the first one who took that vaccine because you believe in that.
Yes.
And while you are trying to help someone, if that person is refusing it, and I'm not saying it's right or wrong, but it may get to that point if they really strongly believe that that's the only way of preventing the bigger spread at some point. Now, Anthony, with this, my next question that I get, and you get from our providers and from our patients, is the booster shot that we call the additional vaccine. Although the guidelines is not very clear, because I think the CDC wants providers to use their own judgments, right? So if we can cover that very quickly, who is going to get the additional vaccine immediately from our population?
Yes, the CDC guidance, first and foremost, the focus of the booster shots is on the severely immunocompromised, and says this will include those who have been actively receiving cancer treatment for tumors or cancers of the blood, those receiving organ transplant, stem cell transplant in the last 2 years, or severe primary immunodeficiencies, or treatment with high-dose corticosteroids. So clearly, within this group, the CDC guidance is pretty clear, but they do make additional flexibilities to allow physicians to use their best medical judgment in determining between patient A and B who should or whether they should get a booster shot or not. So this is the first level of the guidance on boosters. There will be additional guidance coming out as we get closer and closer to the late September timeline, when the larger group of us who were vaccinated and for whom it's been 8 months since being fully vaccinated will then be asked to get booster shots. So as we speak, the focus is on the severely immunocompromised, and that guidance is there. But I should also add that within the larger population, there's some disagreement amongst scientists, even within the advisory committee, which the CDC has, on whether boosters should be recommended for the larger population. Some are of the opinion that additional data is required over the next several months to determine the extent to which the immunity from the vaccine wanes as time goes on. But the data streams are coming through, and the timeline expects that by end September, they should have enough data to determine what the next step should be.
So the other thing that we get the questions around is the efficacy, and we did share some information with our providers as well as the I think it was at the last couple of sessions. So I think I was just reading this last night. Let me actually just bring this up. I think the 24 months after fully vaccinated, the impact on hospitalization is something that they can definitely kind of not guaranteed necessarily, but they can definitely speak safely that those patients won't be hospitalized. So yes. Many people don't understand that vaccines are not 100%. Efficacy is never 100%. No one said
yes.
that. And
yes.
That's what we covered so many times. When we said from the beginning that something is 90%, we know that 10% is going to be not effective. But in decreasing the hospitalization or the severity of the problem is what we are actually talking about here. So this is from CDC, and when we are sharing these types of news, I try. Well, we actually, as a team, we try not to make any references outside of very reliable government sources. Now, if you question the government sources, that's another, problem. But usually, our references are around CDC, and this is the 24 months after the full vaccination. The hospitalization is almost none. For those, but it's never 100%. So yes. I don't know, Anthony, if you want to add anything on this.
Yes, you're right that the primary goal is to prevent severe hospitalization from the effect of the virus, and the two main vaccines being used in the United States, as well as the messenger RNA vaccines and the Johnson & Johnson one-shot vaccines, have been proven to be quite effective in reducing the incidence of severe hospitalization. And you can see that also in the map of the spread of the Delta variant and the daily case rates across the country. The southern states with low vaccination rates are showing very high daily rates of hospitalization. And the percentage of those who are being hospitalized shows about 99% in some cases among the unvaccinated. So really, the data itself is very clear on the impact of the vaccines in blunting hospitalization. As you mentioned, it's not 100% effective, but what it does is be very highly effective in stopping the transition to ICU and all the such. So we're having mild infections, yes. You have increasing case numbers. For instance, about 3-4 weeks ago, we had 1% positivity rate in the state of Delaware. Today, we're about 5-7%. But you can see that the hospitalization numbers are nowhere near what it was at this time last year, even though the numbers are going up. So it's the impact of the vaccination that is slowing this down. So it doesn't look good that we have high case numbers, but as long as those numbers are not transitioning to hospitalization, right, then you can expect that the overall impact of the virus will not be as severe across the country as it is proving to be, especially in the southern states.
You know, one of the as you were talking about that, what I was thinking is, you and I, we are both from different countries, and we live here for a long time.
Yeah.
And both in our home, well, where we were born, this is the home country, but medicine is different in a way that medicine, only in the United States, in the world, we providers, physicians, and we are not physicians, but in medicine, we are liable for punitive damages.
Yes.
Punitive damages is the damages that we are not responsible for, like we didn't actually mean to, but it doesn't have to be originated from our act. But then we are still liable in medicine, in the United States. So what I'm worried about, and now why I say this is because we actually have, Anthony, the main reason you and I, we work together is for our value-based contract. So COVID was something that hit us last year, but we started in 2015. And we try to do population health management, which shows us a lot of liability issues where patients, providers, there are some compliance issues. Now, I spend 2 hours every day with patients on the standard protocols with our nurses team, and what I see is how much we have to push the patients to go through different things to do, like get the clearances for cardiology, get the clearances for pulmonary, do the nutrition classes. Oh, yeah, your A1C is so high, you have to do XYZ. You didn't do the blood work. Average patient, we have to do about 35 to 40 different activities to keep that patient harming from himself or herself. But it may still not be, we may still not be successful. And if something bad happens to the patient, if the patient didn't show up for the appointments, if the patient didn't follow through their specialist appointments, then they can still come back and make us responsible for their own shortcomings. Yes. Now, take this, and then the reason we are just going back and forth with this issue and then just bringing this up again and again is because what I'm hearing is someone is going to get sick and then they're going to say, well, how come you never told me this?
Yes.
If I knew this, I would have done it. Like, I can only hear that in my ear. So that's why we are actually making this, because there's a punitive damage liability for us. And we want to make sure that we exhaust our options. And we talk about this as much as possible so that we are not actually taking any small chance to not to communicate this properly with everyone. So that's part of the main issue that we have.
And you have the additional aspect to this where, you know, what if a patient, for instance, it's a question that I've often pondered. What if a patient from visiting a fully vaccinated patient from visiting a physician's office contracts the virus, the coronavirus? What if that patient comes back to the physician, comes back and holds the physician liable for not creating a safe and healthy environment and therefore exposing them to contracting the virus, right? Is that possible? Could that happen?
It's open-ended.
See, so I thought it was something that I thought about, especially when you mentioned a physician requiring his or her patients to be vaccinated in order to be seen in the office. Because it can be argued that what the physician is doing in making that decision is ensuring the health and safety of both his or her employees as well as the patients who are in the practice at any given time. Yeah.
Definitely. So there are when this is one of those things, I still am not at a point where I can force people to do one way of, okay, I can't just say that you have to, you must. But I'm of course, I'm at a point where I'm just trying to put positive encouragement for people to get vaccinated. But I can also see potential issues, not just for us, but for the society, that this is going to become a problem in different ways from different angles. So our goal is we are open for, as long as there's some level and constructive way, we are open for other suggestions and other criticism, but some of the social media comments are less than serious and almost like comical. So then it makes my point a little bit more stronger on the mandate, because when I see the level of people who are opposing the idea of the vaccine, the level of the comment, like they can actually form an opinion in the social media which is open to public.
Yeah.
And when they make really foolish comments, then I'm like, okay, so this I cannot take this person seriously. So if I'm not going to have an intelligent discussion with you, then your opinion doesn't count. Now, yeah. I don't want to miss the people who are serious in that with that group of people, because there are some people who are in that who are really who have, which we discussed this last week. I had 2 employees who were on the call last week, and they were not vaccinated, and they told us why, and we said, we understand, right? But there's 97% who are making foolish comments on social media, and then they are representing the unvaccinated people in a really bad way.
Yes. The other thing to say about this is that generally speaking, we live in an interdependent and interconnected world, and it's more interconnected than we actually are immediately aware of. In an office space such as ours, we share common space, all right? But not just that we share common space, we share common norms, right? We use the same bathrooms, we use the same kitchens, but we also share norms in terms of our behavior, how we dress, how we speak. And if in an office setting of 100, 95% 5 of the employees are vaccinated, the 95 are actually providing a service to the 5 who are unvaccinated, because the 95, what they do is helped to provide a safe and healthy environment that the 5 who are vaccinated actually benefit from. It's a recognition of the fact that our lives are interconnected in more ways than we are immediately either aware or conscious of, because it happens every day. It happens every minute that we all share the same space. And the idea of herd immunity often is looked at as 70% of the state, 70% of the nation. But more often than not, it's 70% of the people who are immediately around you in an office space or in a family or in a wedding and things of that nature. So it's along those lines that mandates are necessary, but they need to be applied in a way that's thoughtful and selective, right? Because what is most effective, what is proven to be most effective in terms of patient compliance is an approach that leads the patient to a conclusion of the positivity or the effectiveness of a certain remedy. If that person has to be beaten over the head in order to arrive at that decision, it's often proven not to be the most effective way of doing this. So, yeah. So yes, the mandates are important, but they have to be applied in a selective way. I've always thought that. For instance, in the issue of the nursing homes, because you look at the nursing homes, they were the epicenter of the coronavirus from going back to March of last year all the way to the end of last year. They were the epicenter of it. And if you work in a nursing home and you don't want to be vaccinated, right, the question needs to be asked then, what is your understanding of your role in terms of those residents for whom you're, in many cases, the primary caretaker, the person who interfaces with them on a daily basis in terms of their care. And these are one of the most vulnerable amongst us, right? And if the person who is directly responsible for their care is not vaccinated, then a permanent risk exists for that resident.
So that's actually really important. So having that selective way of making that decision, which requires knowledge and approaching it from the different intellectual level, instead of just treating everything same, is not the right approach. So, and that's what we are trying to do from the beginning. And there are so many unknowns, but we can only deal with those unknowns only if we communicate properly, timely, and with the right people in the room. And I think we are doing that. We are trying to do this as much as possible with our state officials. And I know internally we have done a really good job. Anthony, I know these sessions are. For us, it becomes now like a weekly habit, so I enjoy them. And I know you are supporting these, and especially with the provider communication, you have done so much. And thank you for being part of this, and thank you for joining me today. So we have an event at 1:30 with Dr. Erkan, our Bariatric Friday. He'll be joining me, and we'll see you shortly then. Thank you.
Thank you very much.